Well, good afternoon, judges, participants, guests, hosts. We're excited to be here with you today and be able to present the results of 4 months of thought, research, and effort that went into our plan for health partners to be able to address the health inequities brought about by climate change and poor air quality in the state of Minnesota. Today, what we'll be going through first is an overview of our presentation. Next, we'll identify key threats to health. We'll then go into a summary of our 3-year plan and then identify 2 key initiatives that are critical to that plan. In short, our 3-year air quality action plan will result in $25.5 million in avoided healthcare costs by reducing emergency ER visits and hospitalizations due to respiratory illness. There are 2 key initiatives as part of this plan that we'll be implementing. First, improving indoor urban air quality, and second, tech-supported rural engagement.
We're all here because climate change is a huge problem. We know it's a primary concern because it causes worse air quality and creates more serious health problems. That's why we all know the cases of KM and AB. In the first case, KM, a young girl from the metropolitan area of Minnesota, didn't know why she was going to the ER so many times. She didn't know that climate change was actually what was triggering her allergen-induced asthma, sending her to the ER and reducing her life quality and keeping her off of the soccer field. In the second case, AB, an elderly woman in a rural part of Minnesota, never knew how to react on a poor air quality day. This left her feeling confused. And obviously, this would also lead to a lack of mistrust and a lack of use of the health system, and could potentially do so for other people in the rural population as well. So, because of this, we have noticed 2 priority health gaps within the health system here in Minnesota. First, poor indoor air quality in low-income urban housing, and secondly, large distance between healthcare providers and rural populations, notably both geographical distances and psychological distances. This is so important because every 30 minutes, every presentation that's happening today, a new patient is entering the health system of Minnesota, and they're being treated for air quality and respiratory-related illnesses. And this is costing the health system here $30 million a year. We're here to align with the vision of Health Partners. We want to increase prevention, access, and equity for all Minnesota residents across the state and all people within the Northwest region. We especially want to promote these 3 key pillars of healthcare for anyone in rural communities as well as low-income urban housing.
Our 3-year plan achieves that vision by building climate resilience to close those gaps. Each of you judges on your desk should have a copy of our 3-year plan and that discusses all of the initiatives in detail. But we'll dive in to 2 key parts of this plan that span each of the pillars of it. First, improving urban indoor air quality.
So our urban indoor air quality initiative, as we dove into the issue, we found that it disproportionately affects low-income individuals. So this is a heat map that shows the asthma and respiratory ER visit rates between 2017 and 2021. Now what we found is that there are 9 low-income urban zip codes comprising 5% of the state's population that accounts for nearly a quarter of the state's cases. This represents a huge health cost to those individuals. It also represents a huge financial cost to the health system, ranging anywhere from $4.5 million a year all the way up to $7 million a year. Now, why is this the case? Why does this happen? Well, currently there's a disconnect in the system. If we look at it through the lens of KM in the case, KM comes into one of our hospitals or one of our health clinics, and she visits with a frontline healthcare worker experiencing respiratory distress. Well, we interviewed many frontline healthcare workers, and we found that it is nearly impossible to correctly link respiratory distress with the root cause of the issue, so poor indoor air quality, almost impossible. And so there's this need for these outside resources to identify the root cause of the issue. Or as a hospital, we have to refer out in order to link them to the existing resources or equipment that are available. And then even once the root cause of the issue is discovered in the case, black mold, there's very little the hospital can actually do to solve that issue. And so what we're recommending is a systems change. we recommend that the clinic or the hospital become the hub, where when a patient comes into the clinic experiencing respiratory distress, we're able to connect the patient directly with the resources available while they are in the clinic at the time of care. So what does this actually look like? Well, our urban initiative focuses on three key components: social determinant of health questions, strengthening our partnerships, and then focusing on the social determinants of care. The first piece of our urban initiative focuses on the social determinant of health questions. These questions are already asked, and we especially recommend adding the question, has the patient been screened for allergens at home within the past 12 months? If the answer is no, especially for individuals that are at risk or within these 9 low-income urban zip codes, we recommend scheduling that visit. The second component of our urban initiative focuses on strengthening our partnerships, especially with Ramsey County and Hennepin County. All 9 of the zip codes we've been referencing reside within those 2 counties. They, in connection with the Minnesota Department of Health, are the ones who conduct these at-home health assessments to discover allergens. Currently, the system works, we have to refer the patient to the county or to the state, and then they will schedule the visit with the patient. And there's a lot of drop-off in that because it's a complex multi-step process. We recommend simplifying it, strengthening our relationship with the county and with the state to allow us to directly schedule that visit with the patient at the time of care. Obviously, that represents an increased cost to our partners. So how do we justify that to our partners? Well, the Minnesota Department of Health has done studies and found that for every dollar they spend on these programs, they see a positive return to the county and state level of between $1.61 and $5.25. There's already a positive return from these programs. We should be doing more of this. The last and final piece of our urban initiative focuses on the social determinants of care, really targeting the root cause of this issue. The first and key component is to target stricter air quality legislation and regulation. This is a long-term solution. It's not something that necessarily helps KM today. So what do we do in the interim? Well, the 2 other pieces of this part of our plan focus on that interim before we can get the legislation passed, approved, and actually implemented. The first part is comes from our Northwell Health program that they're already doing in Chicago. We recommend offering mold remediation incentives to the landlords in these low-income zip codes. We recommend doing it in a decreasing tiered plan where we would offer a $2,000 rebate to remediate black mold through one of our mold remediation partners in year 1, $1,500 in year 2, and then $500 in year 3. However, even once the black mold is remediated, it doesn't get rid of the moisture problem. That's what's causing the mold in the first place. And so instead of just offering air purifiers to at-risk patients, we recommend also offering dehumidifiers to these at-risk patients to really target that moisture buildup. So that's the urban initiative. If we implement this, what does KM's experience look like? Well, the first time KM came into our system, she would have been asked the social determinant of health questions, where we would have discovered that she had not had an at-home health visit to look for allergens within the past 12 months. That would have been scheduled with her directly at that visit. In addition, during that same visit, because she was at risk and low income, she would have received an air purifier and a dehumidifier. When the home health visit took place within the next 1 to 2 weeks, depending on availability of our partners, they would have discovered the presence of black mold. She then would have been referred to our mold remediation assistance program, where her landlord would be contacted and offered a $2,000 rebate to take care of and remediate the black mold. As a direct result of this initiative, the black mold would have been remediated and KM would not have had to continually enter the healthcare system due to respiratory distress.
The second branch of our climate resiliency plan is what we call tech-supported rural engagement. As we gathered data for this part of the plan, we noticed that poor air quality was actually not more located in urban centers like we thought it would be, but was actually counted at higher rates of particulate matter in rural parts of the state. Similarly, we also gathered data that showed that poverty-concentrated areas nearly exactly aligned with these same areas of poorest air quality. specifically for non-white communities of concentrated poverty, showing a very high disparity for diverse and rural populations. Even more, you can also see that doctors were at a complete lack in these counties for rural communities. So it's no wonder that AB didn't know where to go on a bad air quality day, because she had no connection to her doctor or the health system where she was at all. Because of this, we also want to wrap up these issues and talk about a solution, what we call mobile clinical outreach, where we suggest finding vans and clinical trailers to go to the rural parts of the state and access people where they need it most. By doing this, we aim to reduce distance, foster connection, and improve faster response times so people know what to do when there is an air quality emergency and have someone to rely on when there is respiratory distress happening.
That's right. While these long-term effects of combating climate change are into place, the most optimal way now to address the situation for people in the rural areas is through a pop-up mobile clinic. Mobile clinics go the distance to close the distance. And although it might seem daunting, it's actually straightforward, surprisingly, thanks to specifically some companies and organizations that are already doing this, including the University of Minnesota. Collaborating with the University of Minnesota and other organizations would be a simple way to get into this effort and to expand to these rural areas. If necessary, there's also purchase options prefabricated through companies such as Siemens with grants or funding. When it comes to staffing, minimum, it could be as simple as having a nurse practitioner to oversee the operations and the visits, a medical assistant to help out, and of course a driver. When it comes to these locations, however, it's important to strategically pick some locations that are community hotspots, such as farmers markets or schools. We analyzed the situation and we felt that it would be best if you targeted 3 specific areas with these rural clinics, through educating, screening, and distributing. This is because not only is there a reactive side, an emergency response side for patients like AB when the air quality is really poor, but also a proactive preventative medicine approach, being able to do some screening beforehand and identifying risk factors. So what would this have looked like for AB then if this had existed? Well, she would have already been integrated in the system. She would have known where she could have gone to meet with a nurse practitioner, with medical staff nearby her home. They would have identified not only risk factors that she has to her health, but also identified her distance as a risk factor. She would have been able to receive help like wearable devices and N95 masks for monitoring, for communication, and as well as for when the air quality is poor. She would have known where to go when things were bad. She would have been close to her clinic, and of course, she could have gone to her clinic preventatively and during times of poor air quality, just as she faced in the time of her darkest moments. This requires funding, but the great news is there is a lot of funding available. And I'd like to draw your attention specifically to emergency preparedness grants, which help cover things such as rural outreach initiatives through mobile clinics, as well as draw your attention to the HUD grants, which specifically addresses what Greg was talking about with mold remediation. Now, I'd like to step back and emphasize the importance that our whole plan that we are initiating for both rural and for urban would help save $25.5 million in 3 years by focusing on preventing these current hospital visits that are preventable. Like any plan, however, there are some risks to be aware of, but of course there are strategies for mitigating them. I'll draw attention to probably the biggest risk, which would be legislative advocacy falling short. However, it might not be easy to get legislative advocacy, but it would be easy to go ahead and start working on coalition building and community-based organizations to make sure that we get the funding to help people like AB.
Our plan will have a significant impact on the state, on health partners, and on its patients. Not only will it see short-term wins in that there will be fewer hospitalizations, fewer ER visits, and millions of dollars in avoided healthcare treatment costs, but kids will be able to spend more time in school, get better educations, lead to more fulfilling careers, and have better health outcomes for their whole lives. Further, our adult patients will be able to stay in work towards their goals, and spend their free time not nursing their health, but doing what they love. The ultimate wins of this plan is that AB will be back in her garden and KM on the soccer field. Thank you.